Thank you very much, Chairli Gurmila Mahagad agus Curran Fáilte Rivanara. And I do indeed welcome you, Minister, though it has to be said that the issue that I am raising today has nothing to do with international and road transport and logistics, and has nothing to do with postal policy and air codes. And that's not to take from your very fine contribution as a politician, as a minister. But, I did request that we would be able to postpone this until such time as there was a minister from the actual department dealing with the matter. But yet again, the Shannon is not, I think, being treated with the respect it deserves by the government. Just want to say that, and that's no disrespect to yourself, Minister, or to your commitment or indeed interest in the issue that I am raising. So, the concern I am raising today is about the remote consultation or so-called telemedicine abortion, and specifically the suggestion that that will soon become permanent. It was reported in the Irish Times in an article of the 12th of November that the government intends to make remote consultation and at-home abortion a permanent fixture of Irish abortion policy. Now, we've been living with this policy since April 2020, when it was first introduced as a response to the outbreak of COVID-19. But the suggestion that telemedicine should now become a permanent feature of Irish abortion law is very serious, and this is a radical change to the operation of the law, particularly in contrast to how it was envisioned when the bill was drafted. Because when the 2018 Health Regulation of Termination of Pregnancy Act was being drafted, the then Minister Simon Harris assured members of the Health Committee that under the law, women would be seen physically for consultations, and that, quote, absolutely termination of pregnancy services in Ireland is not going to be done by telemedicine. That's a quote, and that was stated at a meeting of the Health Committee on the 6th of November 2018. In a letter from March 2021, the General Secretary of the Department of Health confirmed that once the pandemic ended, that temporary telemedicine provisions in relation to abortion would lapse. Unfortunately, when most COVID regulations were lifted at the start of this year, the policy of remote consultations continued on. And this was despite the absence of an independent investigation or study into the operation of telemedicine abortion in this country. Indeed, the HSE acknowledged that it's wholly reliant on secondary literature from Britain. Now, if the Government Minister intends to make this radical change to Ireland's abortion law, well, surely it should be done at least in a transparent and open way by bringing forth amending legislation to the current Abortion Act to explicitly provide for terminations by remote consultation. At least then there would be an opportunity for parliamentarians to scrutinise proposals, highlighting indeed some of the issues that have already been raised in this chamber by myself and Senator Keoghan. There are many concerns about safeguarding and physical risks to women's health associated with telemedicine abortion. The HSE acknowledged in a letter of the 3rd of March 2022 that meeting the woman in person increases the likelihood of the provider being able to identify any coercion or domestic abuse. With remote consultations, it's more likely that the most vulnerable women will fall through the cracks. Removing inbuilt safeguards like a physical consultation and the privacy afforded by a GP surgery is sheer recklessness. As was reported in the Examiner on the 24th of October, a teenage Irish girl was locked into a room and given abortion tablets in order to force a termination. That's not an isolated incident. A recent Savanta Comrades poll in the UK found that 15% of women aged between 18 and 44 said they experienced pressure to go through with an abortion they didn't want. Telemedicine enables coercive abortion and makes it more difficult to help the women who desperately need help. Protecting women in abusive relationships and victims of human trafficking, that's what should be the government's first priority. But in the light of these developments, you'd really have to wonder about that and about the government's priorities.
Thank you, Senator. I'm taking this question on behalf of the Minister for Health, Stephen Donnelly. The Minister for Health welcomes this opportunity to update the House on this important matter. I would like to thank the Senator for raising the issue. The model of care for the termination of pregnancy service became operational in January 2019, following the enactment and commencement of the Health Regulation of Termination of Pregnancy Act 2018. Termination up to 9 weeks gestation is carried out in the community by GPs or by doctors working within family planning and women's health clinics, providing clinical supervision and supporting women's self-management. Women with a pregnancy between 9 and 12 weeks gestation are referred for hospital-based care. The arrival of COVID-19 in 2020 required a substantial shift in how care was provided across the health service, including the adoption of measures to facilitate social distancing, reduced personal contacts and footfall within medical facilities as appropriate. As part of the Government's ongoing efforts to protect public health and limit the spread of COVID-19, the Department of Health and the HSE worked together in 2020 to agree a revised model of care which puts arrangements in place to allow termination of pregnancy services in early pregnancy to be provided remotely. For the duration of the COVID-19 public health emergency, where the need for social distancing, reducing personal contacts and reducing burden on medical practitioners are paramount, it became possible for women to access a termination under Section 12 of the Health Regulation of Termination of Pregnancy Act 2018 before 12 weeks from her medical practitioner by telephone or via conference consultation. There is ongoing engagement between the Department of Health and the HSE to monitor service provision, facilitate the smooth running of the termination of pregnancy service and resolve any issues that may arise. However, as restrictions began to ease, it became timely to revisit the model of care, to review its operation and consider whether remote consultation as part of a blended approach to termination of pregnancy care should be continued post the COVID-19 public health emergency period. At the request of the Department, the HSE conducted a review of the revised model of care of termination of pregnancy, taking into consideration the experiences of healthcare providers, service users and international best practice. The review found that the majority of providers within primary care feel that a blend of remote and in-person care is optimal. In-person consultations allow provision of personalised care and allow potential problems to be identified and mitigated, while remote provision improves access for many women and addresses geographical and logistical barriers. It also alleviates some of the difficulty associated with the mandatory 3-day waiting period. The review also found that the provision of a remote consultation as part of the termination of pregnancy service is safe, effective and acceptable to both service users and providers.
Senator. Thank you for your reply, Minister. I think what's going on here is that the advice promoted by campaigning groups, which prioritises ease of access over various threats to women's health and well-being, is what's driving the government. I mentioned the issue of safeguarding, but the physical risks to women's health associated with telemedicine abortion should be addressed as well. If you have no physical consultation and a woman self-reports the gestational age of her pregnancy, if it's done incorrectly and the stage of pregnancy is underestimated, having an at-home DIY abortion with the pills supplied via telemedicine could lead to disastrous health consequences. You could have ectopic pregnancies going unidentified, and if you had a medical self-abortion attempted on that, the potential for a ruptured ectopic pregnancy would be heightened, and that could lead to severe health risks. And I really wonder whether the government cares about any of that, or whether it's just interested at this stage in listening to what abortion activist groups want.
Thank you, Senator. The Government is committed to providing timely access to a high-quality, safe termination of pregnancy service as close to home or the community as possible. With this in mind, the Department continues to engage with the HSE on the most appropriate model of care for termination of pregnancy services, and the findings of this review forms part of that deliberative process.